My name's Barry Powell. I'm a professor of plastic and reconstructive surgery in London. Today I'm going to talk to you about skin cancer recognition. Skin cancer is becoming increasingly more prevalent, and more of us as health practitioners are expected to make an early and accurate diagnosis. What I'd like to talk to you today about the recent NICE guidance on suspected cancer referrals, a look at dermoscopy, then the main section to look at skin cancer and some other forms of rarer skin cancers that you may see in your practice. Earlier this year, NICE, the National Institute for Health and Care Excellence, published its guidance on the forms of referral requirements for skin cancer. And you will see they are established here on the slide. What we are looking at, first of all, is the recommendations for the referral of lesions that are suspicious for malignant melanoma. The 7-point checklist has been around for a while, and it is now being reintroduced into our clinical practice. You will see that the guidance says that at least a score of 3 or more should be made when making a referral, and by that I mean an urgent referral, which we would call a 2-week rule referral. The major criteria are simple. They are a change in size, shape, or colour. It's simple to remember: size, shape, or colour. The minor lesions are where you get a diameter of a pigmented lesion that is between 6 to 7 millimeters or more, history of inflammation or redness, oozing or crusting, and a change in sensation, which some patients describe as itchiness. The other two new referral guidance relates first of all to dermoscopy, as more and more general practitioners are using dermoscopy in their day-to-day practice. So if a GP with special interests notices changes that are consistent with dermoscopy, then that would be an indication for referral. The final one is to identify those lesions that really don't look like melanoma, which are classically described as amelanotic melanoma. And NICE has given due credence to those in order to ensure that they get referred early. Squamous cell carcinoma is an extremely difficult skin cancer to diagnose. So the new recommendations mention that if the clinician has a concern or suspicion that a lesion is consistent with a squamous cell carcinoma, they should be referred urgently. Guidance has also changed with basal cell carcinoma. Traditionally, patients with a diagnosis of basal cell carcinoma were referred routinely, but NICE has now identified a subgroup of basal cell carcinomas that should be considered to be referred on a 2-week rule. And these are where there is a basal cell carcinoma that is large, or it is in a position, particularly like on the face, that could impede vision. For these, the 2-week rule referral now holds. And that is a major change in the referral guidance. Just a word or two about dermoscopy. Dermoscopy is becoming more and more utilised by clinicians, But dermoscopy is something that should not be taken simply. It is not just a case that you can pick up a dermatoscope and start looking at lesions. It requires experience, it requires training, and it requires to be reviewed. There are a number of instruments that are on the market. These are examples. You can see the one that I point to here uses oil immersion, whereas these two are handheld and use polarized light. To just give you a flavour, they are quite expensive, these instruments, and at recent publications, these instruments are quite expensive and vary between £500 to £1,000 sterling. They are therefore not to be bought by every clinician, but those particular clinicians who are interested and keen to improve their skills in the management of skin cancer. These are the kind of pictures and appearances that one can see using a dermatoscope. They are very helpful, and I'm going to give you a few examples where they can be of benefit. This lesion looked very dark and pigmented, but using a dermatoscope, one was able to see it had a vascular component, and the diagnosis was consistent with a hemangioma. This patient could be reassured and did not need to be referred into secondary care. This lesion was sent as a benign mole, but when one uses the dermatoscope, one sees those features that are consistent with early malignant change. And this was an early superficial spreading malignant melanoma, which was cured by surgery. This is interesting because this too is a malignant melanoma. The concern here is that it is growing hairs, and there is a saying that moles that grow hairs are not malignant. Unfortunately, this is not the case, and you must be careful when looking at so-called hairy moles. This was a thicker lesion and required further treatment. This lesion was sent as a potential early melanoma, but the dermoscopic appearances are those of an entirely benign nevus. This patient could be reassured and discharged. This patient was sent with numerous lesions, but the one in particular is highlighted here. Initially, this was thought to be entirely benign, but the dermoscopic appearances are of an early melanoma, once again, which was cured by surgery. This is an obvious melanoma, and you can see the features. We have what is classically described as a blue-white veil. This is where you get sclerosis on the surface of the skin. You get asymmetry of colour. You can see a brown patch, light red, darker black, lighter brown, and you get an atypical pigment network. These three features are the dermoscopic pathognomic findings for a melanoma. This lesion was thought to be benign. Dermoscopically, it also had features that were consistent with an early melanoma. This is all one lesion. This too was a melanoma, and this I put up just to show you a very nasty melanoma, which at presentation has got microsatellites. This is a poor prognostic feature, but you can see the dermoscopic features are equally as frightening. This lesion was also sent as a melanoma, but dermoscopically had all the features of a benign seborrheic keratosis. this patient could be reassured and discharged and did not require any further treatment. And this lesion, which was sent in on a 2-week rule as a melanoma, had all the features of what is called a sunburst sign, and this was a benign pigmented spindle cell nevus of Reed on the knee of a young girl. This was removed, but mainly for reassurance. So the dermoscopic criteria are illustrated here. However, it is not sufficient for one to feel that this is all they require. There are many courses that are held, and I would encourage people to attend them. There are many books and excellent literature that is written on the technique, and I would encourage people to look and read those. And they can be extremely helpful to the beginner. My task is to talk about skin cancer, and we know that there are many different forms of skin cancer, but the three we will concentrate on are the three commonest: basal cell carcinoma, squamous cell carcinoma, and finally malignant melanoma. In the United Kingdom, the incidence has increased. This data from the Southwest Skin Cancer Registry in 2008 gives you an idea of the ratio between these. There is an increase in the incidence of melanoma, which increases dramatically year on year. I want to draw your attention to this piece of work that came out of the British Association of Dermatology, giving you an idea to try and help you in your diagnosis of what might be a benign skin lesion or a malignant skin lesion. And you can see we're talking about, with benign being symmetrical, regular borders, a consistent and uniform colour. From the history, there should be no history of change in size and little evidence of redness. On the other hand, what you would consider be consistent with malignant lesions would be an irregular border. I describe it looking irregular like a map of the Isle of Wight to give you an idea of the irregularity of the edges. Asymmetrical lesions, variegated colours, increase in size, and erythema. So why are we seeing so much skin cancer? I'm not going to go through this in detail, except to reiterate that obviously the sun has an enormous bearing on the increased incidence of skin cancer. More of us take sunny holidays, more of us go abroad. It is easy to travel abroad now, as costs of travel are reduced dramatically. This is what we don't want to see, but unfortunately it still happens in this day and age. Everything is due to ultraviolet radiation. Fortunately, we are not subject to ultraviolet C light. This is taken out by the ozone layer. If we did not have an ozone layer, then our skin would be fried because it is a most aggressive form of ultraviolet light. So the ones that we look at in particular are ultraviolet A and ultraviolet B light. Ultraviolet A is thought to increase the risk of skin aging, with skin wrinkles and everything that goes with that. Ultraviolet B light is more associated with the development of skin cancer. However, we know that the combination of ultraviolet A and ultraviolet B also affect the development of skin cancer. So we know the acute effects of sun with sun tanning, sunburn, but we also now are aware that you do need a certain degree of sun to help you for vitamin D conversion, and many clinicians now in the United Kingdom will agree that patients should have some exposure to sunlight, but certainly not intense or sun burning. Let's look closely at these skin cancers. So the first one, and obviously the commonest, is basal cell carcinoma. We will call it BCC or basal cell carcinoma. It is commonly seen in the head and neck because that's one of the areas that is exposed to the sun. Basal cell carcinomas occur in sun-exposed areas, but is more related to long-term sun exposure rather than the short, sharp bursts you get with summer holidays. It has a classical pearly edge, and the pearly appearance is due to mucin deposition occurring in the cells. There is areas of telangiectasia, and there may be ulceration. So we know it's a very common form of skin cancer. It was traditionally called a rodent ulcer, rodent as in rat, but that was because long ago, before we knew how to manage this condition, it was left and it would slowly eat away at the tissues because that is the nature of basal cell carcinoma. However, it very rarely metastasizes. It is interesting that its appearance changes, and this is important. In the lower of these pictures, which I'm identifying here, we have the typical appearance of a papular nodular basal cell carcinoma, which is classically seen on the head and neck area. On the trunk, the basal cell carcinomas tend to be flat and red. And that's important because they are frequently misdiagnosed and can be thought to be areas of eczema and are treated inappropriately. So the difference in anatomical location is important. It also means that the ones in the trunk area are usually much larger, and surgery is not always the treatment of choice, and other forms of treatment can be considered. Here's a classic basal cell carcinoma. I'd stress again the telangiectasia you can see, the mucin that is deposited giving it a pearly appearance, and the central area of ulceration. They don't always look like this, but this would be a classic appearance. When seeing this, this would be referred under a routine referral system. Sometimes you can get very large ones. They can present very late, like this large one on the lower eyelid. Here's the classic description of what you would call the rodent ulcer. This basal cell carcinoma on the tip of the nose is beginning to eat away at the lower lateral alar. This neglected basal cell carcinoma would cause concern because although it will not metastasize, you can see it's beginning to encroach on a vital structure. And with the new NICE guidance, this would be a basal cell carcinoma that one would recommend is referred in on a 2-week rule. Here's another one arising from a tattoo. Sometimes they can be really innocuous and very difficult to see. Here I've even had to arrow the small basal cell carcinoma on this gentleman's cheek. But there is a technique called the stretch test, whereby if you stretch the skin around the basal cell carcinoma very tightly, you can see the telangiectasia and you can see the pearly appearance. It is called the stretch test. Sometimes they are concealed, and it wasn't until this gentleman presented very late that we found that he had an enormous basal cell carcinoma which he had hidden in his hair. And some, although they don't metastasize, have gone too far at the time of presentation. And this neglected basal cell carcinoma had begun to erode into the anterior cranial fossa. And the treatment for this patient was the new established treatment called vismodegib, which is an oral preparation. Just finally, the H zone is described as that area where it is strongly recommended that patients who present with basal cell carcinomas or squamous cell carcinomas are referred into secondary care, because these can be difficult areas because of anatomical association, and also there may be what are called embryological planes where basal cell carcinomas can actually disappear deep before they spread. And any patient who presents with a skin cancer within the H zone should be managed within a multidisciplinary team scenario. The second skin cancer we're looking at is squamous cell carcinoma. This is an extremely difficult skin cancer to diagnose, and one tends to diagnose it usually by default, but they present with a red, exophytic, sometimes discharging lesion that is invariably also in the head and neck area. But the big differential diagnosis with a lesion such as this would be, could it be a basal cell carcinoma or could it be an amelanotic melanoma? And the only way one can decide is by a biopsy. Squamous cell carcinomas, by their very nature, are referred into secondary care. This is because a number of basal cell carcinomas can actually metastasize and can actually go on to kill the patient. So it is important that they are treated more seriously and more aggressively than basal cell carcinomas. They come in all shapes and sizes. Here is a large exophytic lesion on this gentleman's scalp, which was diagnosed as a squamous cell carcinoma. Here's a lesion on an ear, which turned out to be a squamous cell carcinoma. I will talk about keratoacanthoma shortly, but my tip is do not make a diagnosis of keratoacanthoma on ears. Invariably, they are well differentiated squamous cell carcinomas. This is a patient with a rhinophyma who developed a squamous cell carcinoma. The only way the diagnosis was made here was by biopsy. This is the classical Gulen ulcer, described occurring in chronic venous disease. This patient ended up having a below-knee amputation, but subsequently died as a result of their squamous cell carcinoma. This patient had hidradenitis suppurativa, a chronic infection, and developed squamous cell carcinoma within that area. Here's a patient who had squamous cell carcinoma of the scalp, which slowly ate away at the surface. Some time ago, the management of ringworm in the scalp was treated by radiotherapy. This was offered to children, usually about the age of 6 or 7, who had ringworm, and they were subjected to large doses of radiotherapy. As a consequence of that, in a later life, they ended up developing scalps like this with these indolent squamous cell carcinomas, which are almost impossible to treat. And here's one occurring on the male genitalia as well. They can occur on the backs of hands because that's another area of exposed skin. Behind the ear is another classic area. And squamous cell carcinoma in the head and neck area in men are very aggressive. And at the back of one's mind, one should always consider where there is an underlying other malignancy, such as chronic lymphatic leukemia. I put this slide up to remind everybody that one of the reasons that lower leg ulcers don't heal is because of malignant change. And the malignant change is invariably a squamous cell carcinoma, but it goes undiagnosed for anything up to 1 to 2 years until suddenly somebody decides that the ulcer is not healing, and eventually the penny drops and somebody performs a biopsy. Here's a gentleman with a very aggressive squamous cell carcinoma. This was eroding into his scalp, and at the time of his presentation, he also had lung secondaries. This is another squamous cell carcinoma occurring in a chronic venous insufficiency leg. These are so-called keratin horns. The vast majority of people feel that they are innocuous. About 20% of keratin horns will arise from an underlying, well-differentiated squamous cell carcinoma. And therefore, when managing a lesion such as this, it is important that they are excised rather than just scraped. Here's another aggressive lesion and another squamous cell carcinoma which was spread back into this gentleman's orbit, and at the time of his presentation had also started affecting his meninges. Hopefully we should not see these kind of cases, but they still present from time to time. Here's another lesion on the back of the hand. This too was a squamous cell carcinoma, and you can see the surrounding area which has been marked, which is consistent with a lot of sun damage. Another red exophytic lesion which is consistent with a squamous cell carcinoma. Once again, faced with this challenge, the way to diagnose these is by biopsy. If you are suspicious that this is a squamous cell carcinoma, then it would be referred in to secondary care. I put this one up as a gentle reminder. Here is a patient who was sent in with this lesion on the antihelical fold of the ear. This is Dermatitis nodularis helicis. It is a benign condition and it occurs due to prolonged pressure on the underlying cartilage. These patients classically present with a painful lesion on their ear, particularly noticed in the night time. However, many of these get diagnosed as squamous cell carcinoma. If you make the diagnosis of Dermatitis nodularis helicis, then the management of those is much more benign course. And it is important to make that diagnosis. Whereas you can get this lesion, which is an aggressive squamous cell carcinoma, which is beginning to eat away at the ear, but not only that, but is beginning to infiltrate through all the cartilage. And the only way to manage that gentleman was with a total penectomy. A word about keratoacanthoma. Keratoacanthoma has been described as a well-differentiated squamous cell carcinoma which is undergoing involution. The present situation with keratoacanthomas is that the diagnosis is difficult to make histopathologically and is usually made by the history. If the lesion grows very quickly and rapidly, it is more likely to be a keratoacanthoma. If you try to biopsy these lesions, the pathologist will be singly unhelpful because they will be unable to tell you whether it is a keratoacanthoma or a well-differentiated squamous cell carcinoma, and will ask you to excise the lesion in total so that they can have a better look at the specimen. But I put this up to say this lesion here, because it was on the nose, was a keratoacanthoma. This lesion on the ear, and remember what I said about lesions on the ear, turned out to be a well-differentiated squamous cell carcinoma. So the history is important. The management is dependent on the history, and if the history is short, then one usually can be reassured that this is a Ka or keratoacanthoma. This is a classic keratoacanthoma, short history, and with what's called a collarette, which is this crown-like area which goes around the edge of the lesion. In this position, a keratoacanthoma could be curetted. Here's another lesion, once again on the nose, which is rapidly growing and a keratoacanthoma. But the management is extremely difficult, whether this is a squamous cell carcinoma or a keratoacanthoma. Another keratin horn. This was a well-differentiated squamous cell carcinoma and required a resection of the lip in order to manage this difficult lesion. There's another rapidly growing lesion, but this was a squamous cell carcinoma. Another small squamous cell carcinoma on the back of a thumb, and one on the vermilion margin. These have to be treated usually in conjunction with the head and neck specialists, but certainly discussed at multidisciplinary teams, because they can represent changes along the vermilion border. Another nasty squamous cell carcinoma of the hand, which required a wide resection and a flap reconstruction. Once again, you can see that the diagnosis is difficult because there are no clear features. And again on the ring finger and on the back of a hand again. Here's another aggressive one, which is eroding the bones of the hand, and this gentleman ended up with having a ray amputation. And we see others, and I put these up to stress that these are occurring on the sun-exposed areas of the body, the head and neck and the backs of the hands. This unfortunate lady died from her melanoma, from her squamous cell carcinoma. And another one occurring on the ear, and another classic red exophytic lesion, very difficult to diagnose, but really quite crusty and oozy, and you can see where it's been oozing this crusting around the lesion. One occurring on an old burn scar, and another one on the back of the hand. I have spent a lot of time talking about squamous cell carcinomas because they are difficult to diagnose. This extremely unfortunate gentleman developed one on the columella. These are highly aggressive squamous cell carcinomas, and it is uncertain whether they should be managed surgically or with radiotherapy, but they have a high propensity to metastasize. And you can see these other lesions, which sometimes look fairly innocuous, but with biopsy can be confirmed to be a squamous cell carcinoma. One of the high-risk groups that we still see in our day-to-day clinics are patients who have had transplantation. Because they are on immunosuppression, they are at great risk of developing, and it is usually developing, squamous cell carcinomas. It is such that in this day and age, special clinics are set aside for this particular group of patients so that they can be seen. Most patients who are on immunosuppression will develop a squamous cell carcinoma in their lifetime, and this is the reason why they need to be looked after so closely. This gentleman had had a renal transplant, and these were all small areas of severe actinic damage, but also with squamous cell carcinoma, and also arising on the backs of his hands. There are one other small group that one needs to remember, and these are the ones where there is a genetic predisposition to the development of skin cancers. And this isn't just necessarily squamous cell carcinomas, it can be basal cell carcinomas, and indeed it can be melanomas. The two that we see a lot of are those patients with a condition called xeroderma pigmentosa, and this is a picture of a patient with the condition who had had somewhere in the region of 29 to 30 basal cell carcinomas and numerous squamous cell carcinomas removed since her diagnosis. There is this other condition, otherwise known as Gulen Syndrome or Gulen Syndrome, which predisposes patients to the development of basal cell carcinomas. This is the classic facies of a patient with Gulen's, with a very large, wide-set mandible, and this is because they develop cysts within the mandible. These patients should be diagnosed usually at around puberty, early adolescence, and then should be monitored for the rest of their life. Finally, we're going to look at malignant melanoma. We've talked about the dermoscopic role. I wanted to go away from that because that is a particular expertise that people will develop. But we still use the ABCD for melanoma, and you will be aware that this is for asymmetry, irregular borders, uneven colours, and a change in diameter. So malignant melanoma, we're seeing more and more of it, and it is important for an early diagnosis. If you can diagnose a melanoma early, it can be cured purely by surgical excision. If you leave it late, then unfortunately a number of patients will die as a result of that delay. This is the classical lentigo maligna melanoma seen on the face of elderly people. Usually take a long time to present. They grow very slowly. They continue in what is described as a radial growth phase, which means they grow outwards like a carpet, but they can undergo malignant change. And you can see in these two gentlemen, these are signs of malignant change where it's become darker. Here is the classic appearance of a nodular melanoma. This is not a dermoscopic appearance. This is just as it appeared on the surface, but you can see the irregularities of it and the changes in colour. You do not need a dermatoscope to make that diagnosis. That is simple and done clinically. This is important. This patient was presented with what was described as a pyogenic granuloma and was managed as a pyogenic granuloma. That means to say that they saw their general practitioner and the lesion was frozen. It failed to resolve. The lesion was curetted. It recurred. But unfortunately, this was not a pyogenic granuloma. It was, in fact, an amelanotic melanoma. Here is another similar one and another one. And the rule of thumb here is that be very careful in making the diagnosis of pyogenic granuloma in adults. And this is what NICE has recognised by saying any of those features that could be consistent with a nodular melanoma should be sent in on a 2-week rule. So look out for the pyogenic granuloma and treat it with respect. Melanichia, this is the nail of a young medical student, but this was in fact a melanoma occurring in the eponychial fold. Here's another one on the toe, not noticed because the other toe used to conceal it. And you can see at the time of presentation, that was quite a thick melanoma. Subungual melanomas, very difficult. Usually managed as fungal disease until eventually it is noticed that the fungal disease does not respond, and then the diagnosis of melanoma. To anybody out there, always think very carefully about the management of fungal disease, particularly on the hallux, and that you are not missing a quiet melanoma lying underneath the nail. Here's one on the heel. This is what we describe as an acral lentiginous melanoma. People always describe these as having a poorer prognosis because they're on the foot. This is inaccurate. The only reason they have a poorer prognosis is because they usually present much later and therefore tend to be a thicker lesion. And another one, and there's the dermoscopic appearances although you don't need to use a dermatoscope to confirm that that is a melanoma. I've shown you this one before of a very nasty melanoma, which at presentation has microsatellites. One of the big concerns are these lesions called seborrheic keratosis or seborrheic warts or sun warts. They are frequently referred in as possible malignant melanomas, but they have a classical waxy appearance, they have fissures, and particularly these so-called comedo-like openings. These are seborrheic lesions. They are benign. They don't cause any problems beyond from a cosmesis point of view. And this is a dermoscopic appearance of a seborrheic keratosis, and probably one of the areas where the use of the dermatoscope is extremely helpful in helping the clinician. These lesions present from time to time. People worry about them. They're always thought to be nasty, occurring on a lip. This is what's called an epiphysis or a macule. They are benign lesions. This unfortunate girl of 13 had congenital melanocytic nevi, and unfortunately one of these turned into a melanoma, and she died as a result of that transformation. And these large bathing trunk nevi are also predispositions to the development of malignant melanoma. So I've said enough about malignant melanoma. I'm going to touch on some of the slightly rarer skin cancers. They are rare and they are difficult to diagnose. This slide is of a typical keloid scar of the ear, but I put it up because the following lesion is frequently diagnosed as a keloid and is therefore managed as such. This is a condition called dermatofibrosarcoma protuberans. This is a low-grade sarcoma. They're usually present for many years before they get referred. They are curable with wide excision. They very rarely tend to metastasize, but if they are not diagnosed, they can cause problems. They need to be managed aggressively, because if not, there is a high risk of what is called recurrent disease. So this dermatofibrosarcoma protuberans has been excised with a margin of 2 to 3 centimeters and also in depth. So think keloid, think dermatofibrosarcoma protuberans. Here's another lesion that we see more and more of because it also occurs on a background of sun. This is Merkel cell carcinoma. It's classically seen in the head and neck area of the elderly. They're frequently misdiagnosed as melanomas or as squamous cell carcinomas. This is because they're red, but they tend not to be exophytic. And here's another classic appearance of a Merkel cell carcinoma in the head and neck area of an elderly person. Merkel cell carcinomas are extremely aggressive. They spread rapidly, and usually many people feel that 50% of patients will probably have metastasis at the time of presentation. Here's another lesion which is frequently confused with squamous cell carcinoma. This rare condition called ecrine porocarcinoma is also very aggressive and spreads rather like this with multiple little nodules and disseminates very rapidly. And finally, don't forget these rather odd lesions, which are usually forms of sarcoma. Sarcomas, if you have a concern that you have a patient with a sarcoma, do not interfere with it. Make arrangements for it to be referred to your local sarcoma team. So, in conclusions, when looking at skin cancer, the first thing to say is that the NICE guidance has changed. We now pay more attention to the 7-point checklist. We're drawing people's attention to nodular melanomas that could be amelanotic. We're looking at some basal cell carcinomas, which would frequently be referred routinely, now to be referred as a matter of urgency if they are in high priority areas. It is important that general practitioners are aware of these lesions. Recent evidence shows that 50 to 60% of a GP's workload is actually skin related. A certain percentage of that will relate to some skin lesions. I think it's important that you find an interested GP or colleague who has an interest in dermatology that you can discuss a case with or show them your patients, so long as that discussion or referral to a colleague does not delay that patient's referral into secondary care. Do refer when uncertain. I think in this day and age with medico-legal concerns, it is safer to refer than not to. Finally, there is an onus to the patient. I think everybody expects the GP to be responsible, but there's a certain amount that the patient themselves must undertake themselves. Encourage them to return. Encourage them to take photographs of their lesions and to monitor their lesions, and to tell them that if they notice a change, they should come back to see you. It is desperately important that that is documented in their notes as a point of medico-legal interest. Thank you very much indeed.